Hi again. Our next topic is diabetes mellitus. Okay. So our learning objectives are to understand the definition, diagnosis, and screening for diabetes, the different forms of explain the different forms of diabetes and macronutrient metabolism in diabetes, and also to be able to discuss the complications of diabetes and glycemic index. So diabetes refers to a group of metabolic diseases. However, all of these diseases are characterized by altered blood glucose regulation and utilization, resulting from defects in either insulin secretion or insulin sensitivity or both. So this creates chronic hyperglycemia, which is associated with long-term damage to various organs, especially eyes, kidneys, nerves, heart, and blood vessels, and dysfunction of these tissues as well. So diabetes is becoming increasingly common in the United States. We currently have 9.3% of our population that have diabetes. 21 million of these are diagnosed, and over a quarter of them are undiagnosed. And just think, if people are undiagnosed, then they're not treating, and they're more likely to progress to the complications that we're going to talk about. Okay, so the prevalence in the United States by racial and ethnicity groups is here, and the take-home message to this is that rates are greater in minority populations, especially in non-Hispanic Blacks and American Indians, or Native Americans. So the diagnosis criteria, there's 4 different ways you can be diagnosed with diabetes. The first is a hemoglobin A1C of at least 6.5, and this is actually a new diagnosis criteria as of 2009. Individual can be diagnosed with diabetes if they have a fasting plasma glucose of at least 126, or a 2-hour plasma glucose of at least 200 during oral glucose tolerance test, or a patient can have the classic symptoms of hyperglycemia, such as polydipsia, polyphagia. We're going to talk about all of those, and causal blood glucose of at least 200. So that means it was taken during any time without regard to meal and was at least 200. So for the fasting plasma glucose and oral glucose tolerance test, if one does get ambiguous results, it is recommended that the test is repeated in order to confirm the diagnosis. Okay, so I want to go into a little bit more depth of these. My slides got a little bit out of order, so we'll address that as it comes. But I want to go into these in a little bit more detail. So the for diagnosing with hemoglobin A1C, basically the theory behind this is that hemoglobin A1C is a bound complex that stays where there's so much glucose in the system that it binds to the hemoglobin in proportion to the concentration of glucose that is in the blood vessels. So by measuring the hemoglobin A1C, we're actually measuring this bound complex. And this test is convenient because it's no fasting required. It's a more stable representation of blood glucose over the past 2 or 3 months. Whereas, if you took just a causal blood glucose or a fasting blood glucose, it may not be representative of what the patient normally experiences. So the hemoglobin A1C complex stays in the blood until the heme portion is broken down in the spleen, and that means that this complex is in the blood for as long as the hemoglobin is, which is 2 or 3 months. Another method of diagnosing diabetes is the fasting plasma glucose, and this is easy to administer and low cost, and just entails patient fasting for at least 8 hours and then having their glucose drawn. Okay, the oral glucose tolerance test is supposed to be carried out according to the guidelines of the World Health Organization, and it entails kind of dosing a known amount of glucose, that is 25 grams of anhydrous glucose in water, and then taking a sample from the patient at various times over the next few number of hours. And then finally, we have the causal plasma glucose that I just talked about. So some of the classic symptoms that may accompany that for diagnosis are the polyuria, polydipsia, polyphagia, and unexplained weight loss. Okay, and here's just a graphic that shows that for each of the diagnosis criteria, what the cutoffs are of normal classification or diagnosis of prediabetes, and then actual diabetes. And that's for each of the methods. Okay, so first we have screening recommendations here for a couple of different groups. So the first is for asymptomatic adults. How often should they be tested? And the recommendations from the American Diabetes Association entail that testing should be considered for all overweight adults who have additional risk factors, which are all listed here: physically inactive, first-degree relative, high-risk race ethnicity, which we saw were our minority populations in the United States, a woman who had had gestational diabetes, hypertension, low HDL cholesterol or high triglycerides, PCOS for women, high A1C, or other conditions that are associated with insulin resistance. So if an adult does not fit into these criteria, they should begin testing at the age of 45, and with a negative result should have repeat testing just every 3 years. For testing of type 2 in children, we have very similar recommendations. Children should be tested if they're overweight and have any two of the risk factors listed here. And if that's the case, then they should be tested beginning at onset of puberty and for every 3 years after that. Okay, so we have a couple of types of diabetes mellitus. We have idiopathic and secondary. So the idiopathic diabetes are the ones that we think of traditionally, type 1 and type 2. Secondary are usually that diabetes is initiated secondary to another condition, though it's not completely clear for all of the ones that we'll talk about. So first we have type 1 diabetes. And this is also called insulin-dependent diabetes mellitus. This is defined by the development of ketoacidosis in the absence of insulin therapy. So these individuals have an autoimmune disorder in which their beta cells that make insulin are actually destroyed. So they have they have very, very little or no circulating insulin at all. And therefore, they are not able to take in and oxidize glucose, and the body must depend on breaking down of fat, which leads to ketoacidosis. And this, we'll talk more about that in a couple of slides. So this type usually manifests in childhood, and typically patients do have a normal body weight. So etiology is genetic and potentially some environmental. So some environmental factors that have been implicated in type 1 diabetes include early introduction of cow's milk protein, certain viruses, and cold weather. Now, cow's milk protein introduction before 4 months of age may actually trigger an autoimmune response in response to the bovine serum albumin protein that's found in the cow's milk. Now, these antibodies are also hypothesized to bind to pancreatic cell proteins, and therefore they see, because, I mean, you can just think of the antibodies, see the bovine serum albumin as foreign, the pancreatic cells look the same, they see them as foreign and attack these beta cells. That's the hypothesized pathogenesis. Okay, so, viral exposure to certain viruses has also been implicated in initiation of type 1 diabetes. So stress from a virus can may either initiate this process of autoimmune response to beta cells, or it can exacerbate an already started destruction of the beta cells. So some viruses that have been implicated in the pathogenesis of type 1 include the German measles and mumps, and I don't know how to say this, Coxsackie B4 virus. And some other environmental factors may just exacerbate a condition by simply adding stress to the pancreatic beta cells. Okay, finally we have cold weather, and this is largely epidemiological evidence that demonstrates that this diagnosis is much more common in colder countries, and there are increased diagnoses during cold winter months. So the hypothesis around this is that cold weather alters the body's metabolism, thus increasing stress on the beta cells. And if there is already an autoimmune issue underway with the beta cells, it could exacerbate this and precipitate diabetes. Okay, now we have type 2 diabetes, and this is the most prevalent, of course. So in type 2 diabetes, initially the pancreas is fine and produces insulin, but cells become less and less sensitive to the insulin. So blood glucose, because the cells are less sensitive to the insulin, the glucose can't get into the cells. Therefore, blood glucose increases, but since the cells still aren't getting it, they're kind of sending this signal that they're still hungry. So the pancreas keeps making more insulin, and then we have not only high blood glucose levels, but also high insulin levels. Type 2 does appear to be associated with long duration obesity, abdominal fat, and physical inactivity. And as body fat increases, insulin resistance also increases in the body tissue. So we do call this non-insulin dependent diabetes, but many individuals do take insulin or require exogenous insulin, and that's about half of people, half of adults with this condition. Okay, so we also have secondary diabetes mellitus. So one of them is the maturity onset type diabetes of the young, and this is just a very specific gene mutation that causes all of the effects of diabetes that we've talked about. We have pancreatic disease, and this is kind of the most clear example of secondary diabetes. So either if part of the pancreas was taken out or damaged by cystic fibrosis and pancreatitis, it could lead to the destruction of the pancreas, and therefore pancreas can't do its job in regulating blood glucose levels. Endocrine disease can also be a cause of secondary diabetes mellitus. Some tumors produce counter-regulatory hormones that either oppose insulin action or inhibit insulin secretion. And so some of these hormones are listed here. So just for an example, glucagenomas are pancreatic cancers that secrete glucagon. Cushing syndrome results in excess cortical secretion, and acromegaly results in excess growth hormone secretion. So that and many more conditions can also cause secondary diabetes. Okay, we can also have drug-induced diabetes. So chronic taking of certain medications, including glucocorticoids and diuretics, can interfere with the function of insulin. Mutations of the insulin gene and insulin receptor gene. I'm sure we are all somewhat familiar with gestational diabetes, which sets in during pregnancy. So a higher blood glucose is normal for pregnancy, because we are trying to be somewhat insulin resistant so that our blood glucose can circulate to the baby and give the baby energy. But for some people it goes over and above, and we have hyperglycemia even for pregnancy. So this type usually resolves after childbirth, however. And then I have a number of genetic syndromes here that can initiate secondary diabetes or are associated with it. So some of the common ones are Down syndrome, Turner syndrome, Prader-Willi syndrome, Huntington disease, etc. Okay, so what is occurring to our macronutrients in diabetes? Well, I like to think of this as you either So just think about what is happening. Hyperglycemia, right? So if we have too much glucose in the blood, what we need to do is either find a way to store it or we need to find a way to break it down and use it. So what our body is trying to do is take the glucose out of the blood. So if we have uncontrolled insulin-dependent diabetes, then we have, then again, our glucose can't get into our cells, and our liver says, okay, the cells are starving, I'm going to have greater glucose output so I can help feed the cells. So therefore, the glycogen stores are mobilized in the liver to increase hepatic glucose output. And we also, so to increase hepatic glucose output, it's done in two different ways. So either the glycogen stores are mobilized or gluconeogenesis is initiated. Okay. Also, the hepatic glucokinase is regulated by insulin. So if you'll remember, glucokinase catalyzes the reaction of glucose to glucose 6P, so it can start going into the TCA cycle. And so, so if we have a reduced rate of glucose phosphorylation in hepatocytes, then we have even a greater increased glucose delivery to the blood. Okay, insulin deficiency also impairs non-hepatic tissue utilization of glucose. So insulin impacts the movement of the glucose transporters to plasma membranes of skeletal and adipose tissue, so that those tissues are less able to transport glucose through their plasma membranes. They also, so this results in reduced glucose uptake in the peripheral tissues, and therefore reduced glucose metabolism. So not only are we not able to take the glucose out of the bloodstream, we're also unable to even utilize it for energy. So when we have this increased output of glucose from the liver and increased usage of glucose in the peripheral tissues, we have elevated plasma glucose. Now, because we have this elevated plasma glucose, our kidneys work really hard, have to work really hard to try to reabsorb this back into our body when it's going through our nephrons. And when the levels of glucose surpass the kidney's ability, then we get glucose in our urine or our glucoseuria. Now, glucose is actually a diuretic. And if we just think about what we've talked about before about concentration gradients, basically, if we have so much glucose in our blood, it's going to draw in water and electrolytes in order to help kind of balance it out. And this causes excessive urination or polyuria. And this excessive loss of fluids leads to activation of our thirst mechanism or excessive drinking, polydipsia. So when we have glucose in our urine, we're also not able to utilize the energy for that, and therefore our cells begin starving, and this increases our appetite and food intake, which is termed polyphagia. So next I'm going to talk about lipid metabolism and protein metabolism in diabetes, but we're going to learn a lot more about this moving forward when we get into the lipid and protein sections. So I'm just going to kind of give a very brief overview here of what's important. So again, we want to think about what is happening in diabetes. We have all of this glucose in our bloodstream that we can't really use. So in type 1, the insulin dependent, we also don't have any insulin that can help us either break down fats or help us store fats or store triglycerides. So if we think about it, we have all of these triglycerides in our circulating also, and fats that are circulating, but we have no way to either break them down or store them. So those also stay high in the bloodstream, and triglyceride levels can be very high too. Now, again, we have the same kind of issue as glucose, really, because our body is saying, I don't have any energy, so then the response is to mobilize triglycerides and increase the level of plasma-free fatty acids. So our body thinks, okay, you don't have enough, I need to give you even more. So then again, we have kind of this self-exacerbating cycle where we have high plasma triglycerides. So free fatty acids can be taken up by the liver and other tissues and metabolized for energy, but they cannot be taken up by the brain. In hepatocytes, free fatty acids are metabolized into ketone bodies, and these leave the liver to be utilized as energy by certain tissues when there is an absence of glucose. And the tissues that can utilize the ketone bodies are the brain, heart, and skeletal muscle. However, when they are forced to use ketone bodies instead of glucose, we have ketoacidosis, and this is accompanied by health consequences. So ketoacidosis is also known as a diabetic coma and results from hyperglycemia. So the body can't access the glucose, breaks down fat, waste products are ketones from fat metabolism. And then our body really doesn't have the ability to excrete all the ketones that build up. And therefore, we have this buildup of ketone bodies, which is termed ketoacidosis. And this really is life-threatening and requires immediate attention. So this can cause shortness of breath, breath that smells fruity I think it's from the acetone in the breath, nausea and vomiting, and very dry mouth. And we usually only see this this only occurs really in type 1. So same thing with protein metabolism, just going to go very briefly into it. So if we don't have enough insulin, again, our cells are needing energy, they're starving. So our body works to break down proteins so that our liver and kidneys can utilize the amino acid components for gluconeogenesis so that it can help feed our cells, really. So in insulin dependent, again, type 1, glucose loss and protein breakdown leads to weight loss. So these, they may be of normal body weight, but they are also, especially right upon diagnosis when they haven't been controlling it, these may patients may have too much weight loss despite the fact that they're eating a lot. Okay, so let's talk about some of the diabetes complications, both from hypoglycemia and hyperglycemia. Now, hypoglycemia, low blood glucose, can occur for a number of reasons, but usually it's a consequence of poor management of the diabetes. So it can be because a patient hasn't eaten enough. So they may have taken their medication or their insulin, but they didn't eat enough to provide enough glucose for that insulin to cover it. So therefore, their blood glucose drops way too low. This can happen again if they don't eat enough, or if they do too much medication. Inappropriate medication and meal timing. So timing is really important for controlling blood glucose when we're talking about when patients are giving their insulin, when they're actually consuming their food or consuming their medications. Excessive exercise or sudden increase in physical activity can also cause hypoglycemia. So here are a list of the complications. So we have our early responses: sweating, headache, blurred vision, hunger, weakness, poor coordination, and numbness or tingling. So this just says adrenergic response, and that just means it's activated by adrenaline. So epinephrine or epinephrine. So think about our early response is just a stress response. We're releasing these stress hormones, and we have this stress consequences. And then we have our later response, which is a neuroglycopenic response, which results from a lack of glucose to the nerve cells and has consequences on the brain, including dizziness, confusion, irritability, personality change, shakiness, loss of consciousness, and seizure. So treatment is luckily pretty simple. People with diabetes are encouraged to carry a quick-acting, simple carbohydrate with them. So this could be just 4 ounces of juice, or what might be a little bit more convenient would be people carry around these little glucose tablets that are just kind of more portable. And you're supposed to give a certain dose, in this case, 4 ounces of orange juice wait 15 minutes, take their blood glucose again, and then treat them with simple carbohydrates again if they still haven't resumed normal blood glucose levels. Okay, now let's move on to hyperglycemia, which is the much more common cause of complications in diabetes. So hyperglycemia occurs from a blood glucose of at least 126 and can be caused by excessive food intake, so way too much carb, lack of insulin or diabetic medication, stress. So if a patient is in the hospital, we're almost always going to see high glucose because it's our body's response to stress to raise our blood glucose. And then it could also increase in a reaction to certain medications, so like steroids, which are basically implementing like a catabolism, or a stress response. So potential consequences of the hyperglycemia are diabetic ketoacidosis for type 1 and hyperosmolar non-ketotic syndrome for type 1 and 2, but we most commonly see it in type 2. So this is the hyperosmolar non-ketotic syndrome is frequently seen in older people, and it's usually brought on by something else like added stress such as an illness or an infection. And the body responds to high blood glucose by excreting the glucose in the urine, instigating polyuria. We also have polydipsia in this condition, and this can lead to severe dehydration, seizures, coma, and eventually death if it's not treated. So this condition can actually take days or weeks to develop, so it can be slow progressing, unlike the ketoacidosis, which may be more fast. So here's the same idea as the previous table. So we have hyperosmolar effect of high blood glucose concentration. So the polydipsia, polyuria, nocturia, awaking to urination. So it's just kind of a extension of polyuria. Blurred vision, unexplained weight loss and headache. And then from impaired glucose transport of the cells, we have polyphagia, poor wound healing, chronic recurrent infections, weakness and tiredness, unexplained weight loss, and confusion. And we're going to go into most of these in more detail. Okay, so first we have the polyuria, which we talked about. Our glucose, serum glucose, if in hyperglycemia, exceeds the ability of the kidneys to filter it. So therefore, the capacity is saturated. It brings in added water and electrolytes from the body, and therefore we have increased fluid in the proximal tube and causing frequent urination. Again, the fluid losses signal the brain to evoke a thirst response because we're dehydrated. So it helps us to have a response to drink more. Polyphagia, when we have low glucose, even though there's enough glucose in the blood, we can't get it in to feed the cells, and therefore our bodies mobilize fat and resulting in ketone production and utilization by the brain. And this is a signal to stimulate hunger. It's telling the body it's hungry, it needs glucose. Weight loss results from ineffective cellular glucose uptake and increased glucose excretion in the urine from the glucosuria. It also results from mobilization of fatty acids because the cells are starving, so we break down our fat stores. So the recurrent infections and poor wound healing is one that you'll see in the hospital continually, or repeatedly, I should say. So when we have hyperglycemia, we have higher glucose concentrations in our blood, and we really are unable to heal wounds if our blood glucose is above 150. So just because it's not an environment for wound healing. So this also, hyperglycemia also impairs immune function, which makes wound healing slower. And it's also that our cells are starving, they're not giving the glucose that we give them, and so therefore our body doesn't really have the tools for our immune system to function. Uh, Glucose, high circulating glucose, also can get caught in the ocular lens, causing increase in the fluid because of the concentration gradient, pulls water in, and this glucose and added fluid in your ocular lens can cause vision disturbances. Increase too high of blood glucose can also impact our nerves and damage blood vessels. And so not only do we have the damage to the blood vessels, we also have damaged or impaired ability to carry oxygen and nutrients to our nerves. So not only are they being damaged, they're not getting the tools that they need to be repaired. Okay, so the chronic complications of diabetes are retinopathy, nephropathy, neuropathy, peripheral vascular disease, cerebral vascular disease, and cardiovascular disease. So even though we say, X number of people are impacted by diabetes or die of diabetes, this is a certain mortality rate, we actually have diabetes contributing to all of these other mortality causes for mortality and morbidity. So in 2011, according to the CDC, 21.9% of adults with diabetes, adults over 35 with diabetes, reported coronary heart disease, 9% reported stroke, and 16% reported another heart disease or condition. So these complications are very common. So why do these complications occur? Well, largely because we have this extensive glycation of many molecules and tissues in our bodies. So this includes, our hemoglobin, which we use to measure the hemoglobin A1C. We can have glycosylated lipoproteins such as LDL cholesterol. Glucose actually directly damages vascular endothelium and other tissues, and it can be a source of free radicals, nitric oxide, which is also basically has the same impact as a free radical, growth factors, and altered platelet function. Okay, so let's touch first on our microvascular diseases. So first we have the retinopathy. So this is in our ocular lens, just like we talked about. And this is most common with people who have had diabetes for over 10 years. And this is, that time frame is actually pretty common in our chronic complications. We're going to start seeing chronic complications after about 10 years of having diabetes. So you could have someone that, is 5 years in, doesn't feel like they are really having any negative consequences, and then they kind of get off of managing their diabetes, but then, they can be quicker to progress to these chronic complications. So 2 of the 4 types of retinal damage that occur with diabetes can actually cause visual loss, and 4 million adults with diabetes reported visual impairment in 2011, which is a great increase. And diabetes is actually the leading cause of blindness in adults. And I have 2 retina here. You can see this healthy retina, and you can see this diabetic retina here. Okay, next is nephropathy, or damage to the kidney. And basically, our kidneys are glomeruli are very, very delicate. They're meant to do very delicate filtration work. And when we have hypertension, or when we have increased volumes because of our high blood glucose that is brought in added water, this can really damage those glomeruli. And then we have thickening of the basement membrane and actual increase in the size of the kidneys. A consequence is that our ability to filter our urine actually decreases, and we get protein in our urine, also termed microalbuminuria. And hypertension and infections can exacerbate these changes. And infections are actually very common in diabetes. Okay, next we have the neuropathy, or the damage to the nerves. Um, Basically, chronic hyperglycemia is just toxic to our nerve cells. So when we have damage to our nerve cells, we have decreased pressure or decreased sensitivity to pressure and pain and temperature. And therefore, people with diabetes aren't always aware when they've been injured or when they've been, you know, stepped on something or have some other problem with their foot or extremities because they can't feel it. So they have decreased sensation and they also have poor circulation. And this just creates a perfect environment for like the diabetic foot, basically, where we get these really bad infections, often leading to amputation. And there is a test, it's called the 10-gram filament test, that's just used to measure how sensitive a person with diabetes is, so their level of sensation. Next, we have peripheral vascular disease, which occurs frequently in response to hyperglycemia and is greatly exacerbated by smoking. So basically what happens is, again, we have poor circulation, delayed wound healing, ischemic changes, and this can lead to a loss of a limb or a loss of mobility. And diabetes is actually the cause of 60% of lower limb amputations that aren't from something like a trauma, like a car accident or something. PVD can also cause sexual dysfunction in both men and women. Okay, next we have cerebrovascular disease. So it can lead to, diabetes can lead to stroke and dementia. However, you can reduce your risk by having good control of your glucose, lipids, and blood pressure. And that's really the case with any of these complications. You decrease your risk by maintaining good glucose control through medications, diet, etc. So finally is our biggest one, which is cardiovascular disease. And many people with diabetes die of cardiovascular disease. Basically, our large vessel disease is accelerated with hyperglycemia because the hyperlipidemia, which we talked about when we talked about fat metabolism in diabetes, and the hyperglycemia, if we have all of these in our arteries, in our blood circulation, basically we have increased risk for plaque buildup leading to arteriosclerosis. Okay, so how are our blood glucose levels regulated? I'm sure, well, I hope people have had a lot of exposure to this topic in the past, but basically, abnormal glucose levels, both hypo and hyperglycemia, are trigger hormonal responses to restore glucose homeostasis. So if we have hypoglycemia, basically we have glucagon that is stimulated from the pancreatic beta cells. It's saying we need more glucose, so we need to break down glycogen, we need to have gluconeogenesis. The ACTH, adrenocorticotropic hormone, it can be also released in response to stress, and that inhibits uptake of glucose in the extrahepatic tissues. So it's basically trying to keep the glucose that's in the blood still there to prevent further hypoglycemia. Glucocorticoids are released again in response to stress, and these also inhibit glucose uptake. So again, trying to keep the levels as high as it can. And epinephrine, another stress hormone, stimulates gluconeogenesis and glycogenolysis. So if we have hyperglycemia, however, that triggers insulin release from the beta cells. So this is a nice little schematic here. This just kind of gives an overview. So we have hyperglycemia. Insulin is released by the pancreas, which stimulates glucose uptake in the extrahepatic tissues and also stimulates glycogen formation in the liver, and these actions lower blood glucose. Low blood sugar causes the pancreas to secrete glucagon, and this stimulates glycogen breakdown, which raises blood sugar. Okay, so how does insulin impact our macronutrients? Again, for the protein and lipid, I'm just going to kind of briefly go over. Basically, insulin is saying we have a lot of glucose. So therefore, it's going to promote protein synthesis. So it's saying, okay, we've got all these building blocks. Let's do something with it. Let's build immune cells. Let's build muscle. All of that kind of thing. It's going to decrease gluconeogenesis from amino acids because we've got enough glucose. Insulin's saying we've got enough glucose. And it's going to stimulate the transport of the branched chain amino acids into the muscle and other tissues, and again, promote protein synthesis. For fat, when we have insulin, again, it's saying we have enough glucose. What can we do for this? We need to use it or we need to store it. So it activates GLUT4 to increase glucose uptake in the muscles. It promotes glycolysis by induction of glucokinase. So it's saying, okay, we've got enough glucose, let's break it down and use it. It decreases gluconeogenesis because we've already got enough glucose. We don't really need to make more glucose. And it increases glycogen storage. In addition, it helps retain the glycogen that we have, and again, increases glycogen production. Okay, and then we have the hormonal action of insulin on fat. So insulin is saying we've got enough, so we're going to store the triglycerides that we have circulating in our adipose tissue, and we're not going to break them down for ketogenesis. We don't need to. We have our basically our preferable energy source, which is glucose. We don't need to produce ketones. It also decreases lipolysis by inhibiting hormone-sensitive lipase. So lipolysis is, just a reminder, the breakdown of lipids by hydrolyzing triglycerides into glycerol and free fatty acids. So it's saying we don't really need to break these down because we've got plenty of energy in our system. So it also promotes glycerol synthesis from glucose. So just think we've got a lot of glucose, we need to use it. We can actually make glycerol, and that the net effect of that is that it helps produce 5-carbon sugars for DNA and RNA, and it helps produce NADPH for fatty acid synthesis. So we've got enough. Let's kind of use it or store it in some way. Okay, and then we have the hormone glucagon. Glucagon acts on protein so glucagon is saying there's not enough glucose. So glucagon actually promotes the use of amino acids for gluconeogenesis to make more glucose. For carbohydrate, it mobilizes or tries to break down the glycogen so that we can utilize the glucose in the glycogen, and increases the production of glucose via gluconeogenesis from amino acids and other precursors. So for fat, glucagon again is saying we don't have enough. So it signals the mobilization or breakdown of triglycerides from adipose tissue, saying, okay, we need more of an energy source, and increases ketogenesis because there's not enough glucose available for energy production. It also promotes fatty acid catabolism to ketone bodies so that the brain can have an energy source. Okay, so when insulin is given exogenously, it can either be rapid acting, intermediate acting, or long acting. Here they also, in this graphic, they also have a short acting one. And really, it's just classified according to how quickly they begin to work and how long they're effective. So next we have the glycemic index. And this method ranks foods based on how they affect the blood glucose level. So it's a numerical system of measuring how fast the carbs can actually trigger a rise in our circulating blood glucose. So low glycemic index foods cause a small rise in our blood glucose, while high glycemic index foods cause a big spike in our circulating glucose. So it compares blood glucose levels after eating 50 grams of available carb from a certain food and comparing the rise in blood glucose to some standard. And the standard is usually glucose or white bread, which is standardized at 100. So interestingly enough, table sugar or sucrose actually has a glycemic index of 92. So white bread actually rises blood glucose faster than straight up table sugar. So that's kind of surprising. Also surprising is that baked potatoes have a glycemic index of 121, so they actually raise our blood glucose very quickly. So here's just kind of a list of, this shows how foods are broken up according to their glycemic index. And here's some just examples of different foods with different glycemic indexes. So basically, when we're talking to someone who has diabetes, we want to encourage them to eat the lower glycemic index foods because it's going to cause a slower release of glucose into the body, which their bodies will better be able to handle these kind of lower, slower levels. And it's also going to prevent them from crashing, from having a spike and then crashing. It gives more of a kind of consistent release of glucose into the bloodstream. So just a quick note, when we're talking about athletes, they may also be able to utilize the information that we get from the glycemic index. So an athlete wouldn't want to consume a high glycemic index food just before a race because it would really instigate this kind of spike in glucose and then a crash, which might occur during your event or your race. So we don't want to consume high glycemic index foods right before a race. However, if an athlete consumes a low glycemic index food, it's absorbed more slowly and it's able to provide glucose consistently to the muscles throughout the exercise and can actually cause a release of glucose even as fatigue begins to set in. So glycemic index can be tricky though because you have certain numbers for certain foods that people use, but different factors can impact the glycemic index. So the variety of the food, the processing of the food. So, fine flour has a really high glycemic index, whereas a whole grain of the same grain would have a much lower glycemic index. It depends on how we compare it or what the type of starch is. And if it's a fruit, it definitely depends on the ripeness and how it's served. Is it juiced or is it whole? So one example is that underripe bananas have a glycemic index of just 43, but once they ripen, the starch turns to free sugar and they have a glycemic index of 74 at that point. So glycemic index is totally about quality and not quantity. They're measuring a certain gram amount of available carbohydrate. So if you eat double the amount that they talk about, that they refer to in the glycemic index, basically you're not going to have, necessarily the same glucose response as you would have anticipated. How the glycemic index comes about is, like I said, they give these specific amounts of carbohydrate to a person, measure it against their response to a standard, and they do this in a number of people, usually at least 8 people, and measure their blood glucose at certain time points after consumption. And it's expressed as, the response curve is expressed as a percentage of the mean value for the reference food. So here we can see, and then they average the percentages for each subject to determine the GI. So we can see for the high glycemic index, we have a much larger area under the curve, and we have a crash kind of here. And then for the low glycemic index foods, a much smaller increase and more consistent. So we should definitely give other recommendations for diet beyond glycemic index. That's not the only criterion. Also important is the total amount of carb or fat that fiber and salt that an individual consumes. And really, glycemic index can't be used for foods that are high in protein and fat because they just don't impact blood glucose. And that can be a really good thing for people with diabetes. They can, if they're really hungry, they can eat these high protein or high fat foods without impacting their blood glucose. But too much can still have a negative impact on blood triglyceride levels, obesity, etc. So glucose response can also be variable for each individual. I've had people, that even have increase in their blood glucose from something like a high protein, high fat food like peanut butter. And some foods that do contain carbohydrate, technically, like celery, these are just considered free foods. To eat 50 grams of available carbohydrate from celery would be so unlikely or impossible. So these are considered a free food. And then for my last slide, one big topic of glycemic index is that of rice, because the different kinds of rice have very different glycemic indexes. And this depends on their ratio of amylose to a mylopectin. So remember, the amylose was just a straight string, whereas the amylopectin was very branched. So the long grain rice has the highest amylose, and short grain has more of a bigger proportion of amylopectin, so that branched. So so the amylose, if you think about it, if a product has high amylose, it can only take the glucoses off the end because we just have an unbranched string. Whereas if it's very branched, glucoses can come from all over the molecule. So in addition to the long versus short grain, brown rice has a lower glycemic index compared to white rice. And the rices are listed here, and remember again that those with the high amylose have the lowest glycemic index. Okay, so that's all I have for diabetes, and I hope you enjoyed this lecture, and we'll be communicating next week.